If we talk about grief, some say, well, it's all those emotional experiences that may come up after the loss of a loved one, which is somewhat true, but not entirely. I think it's important to start off by saying that grief is all about separation distress. It overlaps with anxiety, it overlaps with PTSD. I will get back to that, but it also has quite some strong differences. And separation distress, the automatic, partially automatic responses occurring after being separated from an attachment figure, are at the heart of the experience of grief, which manifest in feelings of yearning and longing, proximity-seeking behavior, preoccupation with thoughts about the deceased and also the death event, and the perception as if the other person is still around. So the separation distress is at the heart of normal grief, healthy grief, but also unhealthy grief. And as we'll see, it's qualitatively overlapping, but also largely distinct from depression and anxiety. We are quite familiar, most of you will be, but with the stages of grief. It has long been articulated in the literature that grief, mourning, processing loss runs in the form of stages or phases. But I would be hesitant in following these stages because the grieving processes are mostly individual. And if we say that everybody runs through the same stages, well, it may tend to get too much prescription of what is normal and adequate grieving. So I would not say that everybody shows protest and everybody eventually shows acceptance and everybody goes out bargaining, which is part of the Kübler-Ross model, for instance, because we might accidentally think that everybody goes through the same stages, which is not the case, of course. We all know that from our work with patients and clients. I would rather say if we try to describe the process of mourning, it's more about tasks. So coming to terms with loss means that you have to face the reality of the loss, allow the emotions to be felt, sorry again, and continuing your usual activities as best as possible. And these tasks of grief, quite simple, but they're very powerful to explain to clients, and also offers a nice framework for them to understand what they're going to when they have to cope with a loss. Looking at the prevalence and the nature of emotional distress following loss, a lot has been said about that. A lot of research has been done, and research findings differ because the definitions of unhealthy grief and disorders differ. But by and large, you could say that about 50% of people confronted with loss, also traumatic loss, show a resilient pattern of stable, healthy functioning. About 40% of people initially show increased responses, distress, but they recover mostly with their natural social environment. And approximately 10% of people confronted with the loss of a parent, child, sibling, or close relative suffers from approximately 10% from persistent emotional distress. And this emotional distress comes mostly in the form of what we now call prolonged grief disorder, and also in terms of the more familiar syndromes of post-traumatic stress disorder and depression. It's good to say something about prolonged grief disorder. It's now newly entered in the text revision of the DSM-5. So in large part of the world, we can now formally classify unhealthy disordered grief as prolonged grief disorder. And you can diagnose that formally when a person suffers persistent separation distress, yearning and longing beyond the 12 months of bereavement. So it's not, you don't diagnose PGD in the first year, but only after this first year. This is also something we could address in more depth, but there's not enough time. It's good to recall that the difference between healthy and unhealthy grief, or normal grief and prolonged grief disorder, is mainly that in prolonged grief disorder, the normal acute responses of yearning and longing and preoccupation persist to a distressing and disabling degree, to such an extent that people cannot function anymore and discontinue their usual activities. It may be that in some countries, and perhaps I'm not sure in Ukraine as well, you're more used to working with ICD. And there also newly entered is this disorder of prolonged grief disorder, is quite similar to the description in the DSM, with one important exception, that in ICD we can already classify PGD after 6 months. So earlier on, and this may be relevant not in all contexts in which you work or provide bereavement care, but it may, for instance, in the Netherlands, it's relevant to get the care reimbursed, to get funding for the care. We have to set this formal diagnosis. But it also shows that now finally it is formally recognized that in a small minority of people, grief gets stuck or gets stagnated. Differential diagnostic considerations are, of course, important in clinical practice. This slide shows some of the differences between symptoms of prolonged grief disorder, post-traumatic stress, and depression. And I say that the symptoms often co-occur. So in many of the people seeking help with us, we see emotional responses of yearning, but we also see the typical PTSD responses like anxiety and a sense of ongoing threats. And sometimes people are more or also depressed. In terms of behaviors, there are differences between what we see in unhealthy grief or PGD. People there tend to continue in seeking proximity to the lost person, whereas we know from people with PTSD, they experience hypervigilance and a tendency to avoid stimuli that are associated with the event that they confronted. And in terms of timing, we are very hesitant to say that someone has PGD. We only say that after 6 or 12 months, dependent on the system we worked with. But we know that post-traumatic stress disorder can already be diagnosed earlier on, and major depression too. So there's a clear, that's also a point from this slide, there's a distinction between these 3 symptom clusters that occur often in people seeking help with us. PGD is really about this continuing attachment response, this separation distress. Post-traumatic stress is more about this ongoing sense of threat, of unsafety, and major depression is mostly about lack of motivation and lack of positive affect. If we look at the distinction between loss and trauma, both are, of course, categories of stressful, impactful life events. But we speak of loss if there's a separation from someone or something that you're attached to, whereas we speak of a traumatic event when people witness or experience an event that is threatening to themselves, their safety, control, and integrity. And that's important, in many instances, people suffer traumatic losses, so loss of loved ones, and that's quite pertinent, of course, to the situation of the Ukrainian war. People suffer losses due to war violence, suffer losses due to unnatural, traumatizing circumstances. So what we see, what you see in these people is this combination of intense separation distress and traumatic distress, what we sometimes call traumatic grief. It's not only the grief, it's not only the traumatic stress, but it's really those 2 clusters of symptoms, those 2 experiences that come together. And I will get back to that also in a couple of minutes. If you want to assess prolonged grief disorder in clinical practice, again, I say I can imagine that not every one of you works in a situation where you have to do formal diagnostics or psychological assessments. But still, I would recommend, if you want to assess the intensity of grief, and if you do want to get an impression of whether it's more tending towards unhealthy grief, PGD, or more towards healthy grief, you may consider using this instrument that I will show, a self-report instrument, a self-report questionnaire, to get an indication of the intensity of specific symptoms, as well as an indication of whether someone suffers from unhealthy grief. More from a distance, if we talk to people, what are important distinguishing features between healthy and unhealthy grief? It's about the degree of progress in the grieving process. So people who get stagnated in their process really continue to suffer from this acute grief. Even 1 or 2 years after the loss, they continue to experience as if it was yesterday. So that's an important feature. This has to do with the duration also and the degree of suffering. So if we want to distinguish between normal, quote unquote, healthy and unhealthy grief, we really see people with PGD getting stuck in this intense suffering. They cannot function, they're preoccupied, They suffer intensely from this separation distress that absorbs everything. And that's, of course, what we mostly see, or what we see only in this small group of people. So cutting back to this diagnosis, I would say certainly if you want to have this instrument available to rapidly get an impression of symptoms, severity of the grief, I would certainly recommend you to take a look at what we call the Traumatic Grief Inventory Self-Report Plus. It's a 22-item measure. It's available at the Open Science Framework, and it's also available at traumameasuresglobal.com in Ukrainian and Russian now. With also a brief instruction. So I would certainly recommend you to use it, not to say, well, you are normal grieving or abnormal grieving, but yes, to do get an impression of the intensity of grieving and also of particular symptoms that are particularly intense and standing out and that need your clinical attention. In terms of risk factors, so what are factors that inflate the risk that people end up in this 10% of people with chronic distress? Not much research has been done because the concept of PGD is quite novel still, but still something can of course be said about this. And clinically, these risk factors are important to keep in mind because it helps you to identify the people that are at a relatively higher risk to get stuck in their grieving process. So the more individual people have particular risk factors, the greater their chances that they are likely to suffer in their process of grief. I will pick a few out. So lower socioeconomic status and education is a broadly a risk factor for more problems. The loss of a closer relative with whom one has a mostly stronger attachment relationship, such as the loss of a child or a partner, yields a greater risk of intense, persistent grief. Personality vulnerabilities, it's important to keep in mind that people who are already quite vulnerable to depression, to anxiety, have a bigger chance of getting into difficulties when processing loss. And also people with an insecure attachment style who are vulnerable in interpersonal relationships have a bigger chance of having difficulties coming to terms with loss. So these are all, I think, important factors to keep in mind when talking to people in bereavement care. What this slide wants to show is that risk factors differ from person to person. And I always say, well, you could say that at the right side, the grief, the traumatic distress and depression, the intensity of these symptoms is the outcome, is the result of different factors working together. So at the left-hand slide, people suffering loss, they lose an attachment figure, which is already quite dreadful in itself. In some instances, violent loss, war, sudden losses, there are traumatizing aspects of the loss. So people sometimes suffer loss in the context of war atrocities. People lose loved ones who have been tortured under the most dreadful circumstances. So all these traumatizing elements of the loss event add up to the loss itself, making the loss even more complex to process. And then there's this other block of events after the loss. So in some instances, many awful, traumatizing, painful thing happens in the aftermath of a loss. There's this damaged body or people gone missing. There's this police investigation or a lack of investigation. There's a lack of recognition of the loss. So all kinds of things may be happening after the loss that in themselves are very traumatizing. So I sometimes make a picture like this with my client to see, well, what characterizes the loss that you experienced? What are for you particularly traumatizing aspects of these circumstances of the loss that are very distressing to you? What happened after the loss that you still are so much in pain about? So to draw this picture of all those variables and factors working together in affecting the grief and sometimes also the traumatic distress and depression. And of course, there are other variables and factors that are also impacting on the way people grieve and the intensity of grief. So social support is, of course, an important factor. It can be a protective factor when there's sufficient and qualitatively good social support, but it can also be a risk factor if there's a lack of social support. And in the context of war, there are several other potential contextual factors that make the distress or the risk of distress even bigger. So the ongoing stresses of war, of course, may make the processing of losses even more painful and difficulties. And of course, we as providers of bereavement care need to keep that in mind. If someone suffers a loss, it's not only the traumatizing aspects, but it's also all the other variables and all the other factors and all the other things happening around that loss and in a person's life that all affect the grieving of the person. A cognitive behavioral perspective. Well, from this cognitive behavioral perspective, and I have to say it's one theoretical perspective of many different theoretical perspectives, but I have done quite some work with it also with clients and patients. And I think, and I will try to show that it gives a nice framework to provide several interventions. So this CBT perspective proposes that unhealthy grief or prolonged grief is actually acute grief that has become chronic. Why? Because the irreversibility of the loss, the reality of the loss is insufficiently integrated with the person's self-identity, working model, relationship, worldview. These are all difficult, complex words. I realize that, but I will say a little bit more about that. The person develops persistent negative cognitions, is another factor that makes the acute grief to get chronic, and the person engages in avoidance behaviors. So zooming in on each of these processes and also linking them a little with interventions. So the first process says that problematic grief, the risk of problematic grief increases because or as long as the loss is insufficiently integrated. And this picture tries to show that we all, you could say, have our internal reality with working models of relationship, of ideas about our identity and role, and perceptions that the world is safe and predictable. And when a loved one dies, there's this external reality. And in normal, healthy grief, this external reality gets connected with this internal reality. But in problematic grief, this occurs insufficiently. It is as if the death of a loved one is sort of a disconnected reality, disconnected from the rest of the brain almost, or to put it in other words, it's the death of the loved one is disconnected from a person's life story. And as long as that's the case, this CBT approach proposes then separation distress, yearning, searching, and all the other symptoms of PGD tend to persist. And this is all very nice, but it's even nicer that this has implications for treatment. And I think this is perhaps the core of bereavement therapy or grief therapy. And it's the core of CBT therapy, that what we try to do is to get this reality, this external reality, the fact that the loved one is really dead and will not return. We want that to get connected with this internal reality. And of course, our clients tend to avoid that reality. They don't want to think about the loss or don't want to think about the implications because it's too painful and too intense and too sad. So what we try to do, or what we should try to do in grief therapy, is to help the person to integrate this reality of the irreversibility of the death into this internal reality. And we do so by using writing assignments, therapeutic rituals, but particularly by using exposure. And two forms of exposure are particularly central to CBT grief therapy, and I think to all the bereavement care that we do. The first is exposure to the story of the loss. So what's really important to do with people seeking help with us is to talk about what happened, to help reconstruct the story of the loss, starting from the moment the person knew that the other person was dead or was going to die until the actual funeral took place. So to really reconstruct what happened. And this all helps the person to gradually confront this reality, to give words to this reality of the loss, and to integrate this reality into the life story. Apart from that, exposure to the irreversibility of the separation means that what is important to do in grief therapy is to really talk about what it means that the other person will not come back. And you might say, well, the client knows that his or her child died or his or her partner died, but it mostly when people get stuck in their grief, they know rationally, but they don't know it really at an emotional level. So really talking about this irreversibility, what it means that a child will never return, what it means that a partner is really gone, will never return, and hold still with that reality and really experience the pain is central to grief therapy. And it's obviously a very painful and hard process, but it's very helpful to people who get stuck in their grief, particularly when we as therapists are there for them, provide a safe space, provide comfortable and solace, and then the person can gradually start coming to terms with the loss. So that's central to CBT therapy, and I think again to more generally to bereavement care. So the second process, the first process states that, well, the loss is insufficiently integrated into the life story. Using exposure, we facilitate this integration. The CBT approach also proposes that negative cognitions, intensely negative, unhelpful cognitions, also play a role in people getting stuck in their grief. And this is, of course, a familiar assumption of CBT. CBT proposes that negative, maladaptive, dysfunctional cognitions drive or cause psychopathology. And in the context of prolonged grief, there may be different types of cognitions that, well, make the grief chronic. So on the slide, there are different examples. So people may come to think extremely negative about themselves or negative about the future. Of course, people may engage in intense self-blame, being convinced that they should have prevented the death, or other people are responsible, other people must be punished, I will never rest before the other people are punished. Such cognitions, as another example, may inflate feelings of anger, hate, and revenge. These are examples of cognitions that may play a role, but of course, in every individual person, these may differ. So for some, cognitions about self-blame are quite central. For others, it's more extremely pessimistic view on the future or life that drives the problems. And cognitive restructuring, as we also know, or many of you will be familiar with from other treatments and other problem areas, cognitive restructuring is a very powerful tool to identify these problematic cognitions and to start raising some doubt about these cognitions. And modifying cognitions, that is what we try to do in cognitive therapy, and that's not an easy job. Most of you will know changing cognitions is not about saying that, well, you think wrongly, you should think more positively, then you will feel better. Of course, it's not so simple, particularly when people have experienced devastating loss. So we don't go out there discussing about cognitions, but we try to search for cognitions that can be falsified. So if people say, I could have prevented this loss, it's hard to falsify the cognition. So we're going to look for a cognition like the fact that I didn't prevent the loss means that I'm a bad person. So in many instances, those types of cognitions go behind cognitions about self-blame. So the point here is we don't just go out discussing about every cognition, but we try to search for cognitions that really drive the problems and that we can try to talk about and raise some doubt about. Using Socratic questioning is important, and I pick one thing out. It's particularly important also to address the usefulness or the helpfulness of cognitions. So if a client says to me, well, my life is useless since my partner died, I'm not going to say, how do you know that that's true, or what's the evidence? I'm going to, instead of that, I'm talking about how does it help you to think like that? What's the consequences if you continue to be convinced that you will never be happy again? So talking about cognitions in this way, but also respecting the view of the person, of course, is a delicate and elegant and a process, and it's not about helping the person to think more positively. Challenge with behavioral experience, that's something that CBT therapists like to do. So, and many of our clients turning for us for bereavement care, they have these negative predictions about the support of others, or negative predictions about the bearableness of their feelings. And you can set up behavioral experiments to test these predictions out. So people who are very negative about the impact of going out with friends again, saying things like, if I arrange to meet with that friends, I will not enjoy it. Well, with someone like that, you can set up a behavioral experiment to test that assumption. Say, well, okay, phone up that friend and see if you can make an agreement, if you can go out together and see what happens, see how your friend responds. And if your friend responds negatively, well, let's talk about what you can do then. So this is all about helping your client to do something to test out negative cognitions. I have to be aware of the time, of course. The third process says that, well, avoidance behavior plays a role in the persistence of grief. So there's one form of avoidance that we call anxious avoidance. Many of our clients tend to avoid thoughts about the implications of the loss. They don't want to think about the circumstances of the loss, or they avoid stimuli associated with the irreversibility of the loss. And in most instances, this has to do with sort of catastrophic, anxiety-provoking cognitions, like if I confront the stimulus, or if I allow myself to be sad, I will go mad. I won't be able to bear those emotions. So it's almost like a phobic-like avoidance, what we see. And here again, exposure is important. So what we do is we look at pictures, we look at footage, we look at letters that the deceased person wrote. We help the person to confront cues that are reminders of the lost person and the loss, not brutally and abruptly, but gradually, but certainly so, to help the person gradually confront the stimuli that are connected with the pain and connected with the loss. A further and final idea from the CBT model, final assumption of the CBT model, is that depressive avoidance plays a role in unhealthy or problematic grief. And of course, it's very logical that if people have experienced loss, that they don't immediately go out to their work or social activities, or engage in recreational activities. But if this passivity continues, then the grief also continues. So particularly when those cognitions that, as I put on the slide, are underlying those, when people predict that they will never enjoy going out, or that they don't deserve any pleasure anymore, if those cognitions drive passivity or depressive avoidance, it's very helpful to help our client, the help seeker, to gradually re-engage in activities again. It's a simple principle, but it's very powerful. And the principle is, if you gradually become more active, you go out of the house, meet with people, you don't have to feel happy, of course, but if you try to continue do stuff, preferably in keeping with your values and goals, that will help you. That will help you to distract from the pain. That will help you to integrate the loss into your life. It's difficult, but very crucial to come into terms with loss. I'm almost moving to the end, I think. Key goals of therapy, key goals of the CBT therapy. So CBT therapy or CBT counseling is not about removing the grief. It's not about taking away the pain. It's more about changing the stagnated or unhealthy grieving into a process of healing or healthy grieving by working on 3 tasks. That this is how we explain it to people. It's about facing and not resisting against the reality of the loss. That will help you. That's a thing that you have to achieve. It's about facing the implications of the loss and the pain that goes with it. That's all part of the first task as we distinguish it. Keeping confidence in yourself, other people, life, and the future. That's an important task too. So we don't say you have to think more positively, but we say, well, it helps you to try to regain and keep some confidence in yourself. Engaging in helpful activities that promote adjustment, easier said than done, but so crucial and important to turn the stagnated grieving into a healthy grieving process. Just touching briefly upon some additional interventions, I focused on CBT and as an example, writing assignments. You are all, I think, or most of you will be familiar with those. Writing assignments can be very adequately and accurately embedded into grief therapy and grief counseling also from the CBT framework. And I would always urge you or always encourage you to use writing assignment, particularly a thing like the ongoing farewell letter. I always give my clients the assignment to continue writing or to start writing this farewell letter in which they articulate all the things they want to say, in which they articulate their love, in which they articulate also their pain, and in which they articulate what they are missing most now that this person is gone, to confront this reality of the loss. Rituals, it's not a typical cognitive behavioral therapy thing, but rituals are of course very important to mark the leave taking of the deceased, or to express thoughts and feelings, and also to mark a transition to a new phase or role, particularly in circumstances when a person did not have the opportunity to take leave, where funeral rituals were interfered, where there was little social support. It's very important to help the person to redesign or design some leave-taking ritual to really mark the transition to a new phase and to mark the goodbye or the transition to a new relationship with the deceased person. The effects, I think I have to move to the final remarks. I'm going to back to, it's mostly because I'm saying something about EMDR, because I often get questions about, can we apply EMDR? Yes, you can, but EMDR is not a helpful tool to curb, to target, to reduce the separation distress. But EMDR, eye movement desensitization and reprocessing, can be very helpful as an additional intervention if people are plagued by persistent traumatic distress connected with specific images. So if people continue to relive images of the death or something like that, then EMDR can be a very effective intervention. Generally, I don't present figures in this presentation, but the effects of CBT are all quite positive CBT interventions. But of course, we still have a lot to win, because there are quite some people also not improving sufficiently. But that's something we have to keep working on. Some final remarks. Many people are resilient in the face of traumatic loss, resilient as in experiencing relatively stable, healthy functioning. They don't need intense therapy. They do need social support, of course, but not psychotherapy. But loss can lead to severe emotional distress in a minority, can lead to PGD, PTSD, and depression. Sometimes people are very hesitant to use the term PGD, and I'm hesitant too, but in those people who are really suffering from their grief, it can be very helpful to explain to them what prolonged grief disorder constitutes, which offers something of an acknowledgement of their suffering, and it also helps them to find the right place for help. The CBT perspective helps us to understand the persistence of distress. It's not the only theory, but it's a very clear theory that helps us to understand why things like exposure work so well. In bereavement counseling and therapy, it's important to disentangle the many variables that may inflate the grief. So thinking back of the risk factors, it's good to make a picture of the possible risk factors with our individual clients. What has inflated the pain in our particular clients? Be aware, of course, of current ongoing stress. Give room to the story of the loss. That's always important. Have people just tell the story of what happened, articulate their pain. This is, well, most of us will do that naturally, I think. And well, you can be aware that that's actually a very good thing to do with grieving clients and help seekers. But confronting the reality and irreversibility of the separation, which sometimes people really continue to avoid, is critical when people are really stuck in their process. So really talk about what it means that the other person will not come back is critical to that process. Involving a supportive person, I think, is another good thing to keep in mind when doing bereavement counseling and therapy. And I think there is where I have to end today. But I do want to say this. We are working, my colleague and I, Lonneke Linfink, on a new initiative, the development of a psychoeducation intervention for people from Ukrainian experiencing intense grief. And it's a call if you want to share questions and wishes or ideas about what should be in such a psychoeducation intervention, don't hesitate to email me. I really want to learn from your experiences because you're the ones who are doing the work. You're the ones who are meeting these clients. You are the ones who have particular questions, and I would like to help in getting these answered. So please share your thoughts, wishes, ideas, and suggestions to me about that.
Thank you very much, Paul, for this really excellent talk. I think there is a lot to learn from this, and I think there is some time for some question. Let me start. There are some thoughts about using benzo or against using benzo right after exposure to traumatic event in regard to PTSD. What is your take about using benzo in grief?
I have to first start. I'm a psychologist, not a psychiatrist, so I have to be very. I'm not allowed to say very much about that. But based on having said that, based on my experiences working with psychiatrists, of course, I would not promote it. I would not promote using benzos. Of course, and you know much more about that than I do. If people don't sleep and don't get the physical rest long time after their loss, and that really interferes with the grieving process, and that really interferes with the therapy that you want to do, then you might consider applying benzos. But I would be very hesitant. It doesn't. That's what we know from the little research that has been done. Is doesn't take away the grief. Of course, I'd say.
Actually, some people claim that it might prevent the spontaneous recovery. So yeah, okay.
Yeah.
I see there are two ends. Olena? Olena
Tiutiunnyk. Добрый вечер. Я хотела бы спросить.
Good evening. I would like to ask, what could you advise to the therapists? What would be a measure to avoid the burnout? Because we are engaged in the processes, we work with trauma a lot. So how can we avoid the burnout? Thank you.
Thank you. If I understand it correctly, the question is how can we as caretakers ourselves providing the care prevent burnout? Well, I think it's good to, well, it's a bit obvious to say, but it's important to try to stay healthy ourselves as far as possible. So don't see 10 persons a day for an hour, and make sure you have some time off and engaging leisure activities. Get colleagues. So if you're working alone, make sure that there are time and space to meet with colleagues in a intervision, as we call it, or a group setting where you share your experiences and also share what you find difficult. I think it's a very important question because grief therapy is really about providing this solace, this comfort, so it's about pure and real emotions, as in trauma, of course. So it can be very stressful to us as well. So, but particularly the talk with colleagues, make sure that you meet with colleagues to share your experiences. I think that's critical.
Yeah, thanks. I think it deserves a separate topic, like a prevention of burnout in caretakers. We would think about it. Thank you, Elena, for raising this question, obviously. And we have 2 hands here, and we will listen to Iryna and Olena question. But before that, I think this would be important for you, Paul, because you mentioned you are looking for information, what would be important for your psychoeducation program. So we have in Ukrainian here several questions related to a situation when relatives were not able to receive body, so there is no body, so they cannot grieve. And for example, in contrast, somebody cannot attend funeral, so because of health or because of, I don't know, some issues with yeah. So what would be your advice?
My advice would be, and again, easier said than done, try to think of a way to do some ritual and arrange some ceremony. And it doesn't have to be, or it cannot always be a bigger ceremony, but make sure to do something special, engage family, engage friends, well, celebrate the life of the person, grieve together, have a good meal. Things don't have to be fun, of course, but make sure to do something that's really special and that marks the loss. And perhaps also there will be some time that you can do a real funeral, or that you can do a bigger ceremony when normal times return. But arranging a ritual is really very crucial there, I think.
Yeah, and so we have actually a great comment as well from a colleague of ours, Oleg Volkovsky, who said about the ritual kenotaf, which is the grave without body, and as well his personal experience when he was recording the funeral for somebody who was not there.
Yeah,
for somebody who was not able to. Okay, so let's switch to 2 questions, 2 hands we have. Then we will have Halyna presentation, and after her presentation we will have some time left for discussion, so we will go back to the questions in the chat. Iryna Lishuk.
Good evening. I would like to say thanks for this very interesting presentation. I'm a graduate student in the medical psychology and psychotherapy department in Kiev Medical University. So my work is related to grief and loss. So my question is, do you plan a study on validation of the traumatic loss scale in Ukrainian sample, and if it's planned, if we can join it?
Thank you very much for this question, and again, it makes me think it's such an honor to be here, standing in my working space with you all, working in these difficult circumstances. So my deep respect for that. But your question is, will we be validating the traumatic grief inventory? Yes, we have planned to validate the Russian and Ukrainian translation. So if one way we can collaborate in some way, or do you have ideas about how we can do that or make that process better, please email me, and I would look forward to collaborating on that. But we do plan to study the psychometric properties of that instrument, yes.
Yeah, thank you, Iryna. And Olena.
Good evening. Thank you for this very interesting presentation. My question is on how one can apply written tasks if the loss is undefined, if you work with the relatives of those missing in action.
Yes, again, a very good question, and I don't have, it's a difficult question. If someone has an idea, please come forward, a step forward. I think with people who have people gone missing or missing in action, they're mostly different scenarios. So the other person might be dead and never return, but it might also be possible that the other person might still return one day. And people often have those two scenarios. And I would use writing assignment also to write about those two scenarios. Write one scenario and the other scenario, because we don't know what's the true scenario, but we know that our client is actually thinking about both scenarios. So putting this in formal terms, I'd say, well, do exposure to the situation in which the other person is really dead and gone, but also expose yourself to other scenario. And that, I think, helps to canalize the feelings. It sometimes also corrects some ideas about the possibilities that the other person will return. And more generally, that's what I do when people gone missing. It's exposure to all the possible scenarios, including the scenario that the other person, well, including, I have to say, the scenario that you will never know for sure what actually happened. That's also something that sometimes people have to process.
Yeah, thank you. We definitely can go back to Ukrainian experience with this question during the discussion. Thank you very much, Professor. And it's an honor to invite Halyna Tiutiunnyk. I will not spend a lot of time introducing her. She's a psychologist, EMDR, and positive psychotherapy psychotherapist working with trauma. And please, Halyna, the floor is yours.
Thank you, Paul, for this very interesting presentation, especially the tool set on CBT. I know that it's very effective, helpful. It was very important for me to hear about social support, because this is the topic which I want to mention today. Leadership during losses, especially massive losses, which we see. I've seen several times when some random deeds or words of the leaders, who are either opinion leaders or influencers on social networks, they really harmed grieving. The behavior of the leaders and what the leaders are doing in crisis situation and during losses, it affects the communities or units. If we talk about the military, the way leaders respond to losses plays an important role in how the communities and individuals process grief. Understanding the processes which happen during grieving, understanding the needs of people, and exchanging information, it all helps leaders understand how to move on and how to effectively manage the communities in processing the grief. So the leaders, what should they do? Of course, here we can talk a lot, but as the time is limited, I will be essentially presenting the bullet points. So the leader, if they want to ease the community's processing of grief, they have to stay in contact. They have to communicate, effectively communicate with the community. These would help fill in the void, and the rumors will not be going on. And the leader also has to provide accurate information about the number of the deceased and, if possible, about the circumstances of death, and where the relatives can find out accurate information. Also, if something is unknown, they have to admit it, but they have to say when will this information be available. They have to be honest in this. I've seen several times when the leaders simply just gave the information that there's that number of people killed, and then the relatives were just trying to call on possible numbers, what happened, and they couldn't get any information. Also, using several information channels and understanding what is important to consider in grieving. Here, as psychologists, we have to help. We have to help the leaders. We have to share our knowledge. We have to explain and raise their awareness. We have to explain how to provide this information, because people process information differently. So it's important to word all these messages in simple terms and repeat them. The leader also should show the continuity, what was in the past, what is now, and what will be in the future. Also, the leader should facilitate cohesion and creating this social support for the families of the deceased. Also, establishing shared objectives. This is important for the community if they have a shared objective, and being present in bereavement rituals. Also, translating self-care and being an example to follow. The leader should normalize processing losses with their own example, and if possible, they should master the art of counter concepts, because some messages are very typical and people repeat them in order to not get stuck on this. If the leader, let's say, broadcasts a different opinion and shows a different concept, it would help people not get stuck in this negative concept, which would promote this traumatic grief. The role of the psychologist. We have to go out of our offices and we have to raise the awareness of the leaders. We have to guide them. But of course, it's the leader who has to communicate to the community, because they use the authority and the confidence of the community. The psychologist doesn't have that authority and trust. Another thing I would like to mention is how we process losses during war. Before the war, we were processing individual losses, so to say. Yet, of course, sometimes we have seen some catastrophes. We know, for example, that there were the Chernobyl accident, and there were also mass accidents like the Sknyliv airfield accident, and we've seen the MH17, also the downing of Ukrainian airplane in Iran near Tehran, and of course it was providing impacts for Ukraine, but essentially it mostly touched the relatives of the deceased. But now it's like we are living in constant loss, and these losses, they touch the whole network. It's difficult even to find people untouched, and every day the losses are mounting, and they're getting more and more, and we can't process the previous one, and the new ones are coming, and we need somehow uh, process this. If it's an individual loss, if somebody is if somebody is missing in action, it's just a separate topic indeed. These undefined losses, it's difficult. But now this grief is no longer individual. It's like a collective thing. We all have to live it through. We have to process it. Now, grieving is deeper, it's longer. There's so much grief and it's so unbearable that sometimes our psyche just creates a distance. So there's a glass wall created in between. We encounter losses, but the response very often is that we are distanced. Many clients are saying that these experiences are kind of unavailable for processing, and they think, what's wrong with me? My heart is stone now. But its normal response is just too much grief.
But at a point, this wall can collapse you and barrage with all the emotions that were behind them all. And that at that time, people react. So I did not react to my funeral, and then I saw a dead kitten and I just lost it. So this tiny detail can trigger the experiencing of the entire grief. Can we say that we will go through loss as before? Yes, because our psyche has some coping mechanisms. This is not the first war in our territory. This is not the first case where we lost many people at the same time, and it's lasting. But what about the majority? Well, for the majority, it's an individual challenge, an experience we didn't have before. And there are some features that would affect our grieving. It's worth researching, and it's something we need to take into account as professionals. I know for a fact that we will survive this. This is a dialogue that you can see in the slide. It's a dialogue from an American TV series, by the way. So it's the father of the dead and the fellow soldiers. The father said, I live for him, but I never told him. I didn't want to burden him with that, but now I want to hide from everyone. If I don't feel pain, I think that I didn't love him enough. And then the fellow soldier says, we think that pain is the only way to express love, but pain is no love. Pain is just pain. With that, I'd like to segue to leaders, to talking about leaders in the context of war losses. There are nuances here. Grief is a very difficult emotion. People often avoid it, including the leaders from the military. They only seem so strong, but they need to project strengths. They don't need to shy away and start a quiet game of drinking. They had to get out there to talk to the personnel. They have to be engaged in all that. A leader needs to acknowledge losses. If you don't do it, you end up with information void. It will be filled with different fantasies, and this only dampens the spirit of the unit even further. The leader needs to know about the grieving stages. He needs to be frank in demonstrating his sadness and his bereavement. It's not about unfolding emotion. It's about acknowledging emotions, about giving them space, but folding them back again and carry on with your missions. It's about that. A leader needs to demonstrate their emotions so that the soldiers know that emotions are natural, that the leaders also have feelings, and that each individual is not alone in feeling what they feel. The leader needs to organize farewell rituals. They need to create opportunities to visit the funeral if it's carried out in a different unit. They need to set the example of going through grief, about recovering, about motivating them for positive future. They need to do goal settings, and they need to restart routines. They need to work with the values of their subject, especially working with guilt. It's about concepts and counter concepts. One of the worst fears of the military is that their death would be in vain and that they would be forgotten, and they need to work with that. And the soldiers need to look at the world not only through the eyes of fear, but also see that what they do is not in vain. that their actions are encouraged. So how can that sound too much? For example, we fought, Mozart died. We will pray together now, but our mission stands. We will do this and that, and after the victory, we will visit his grave and say goodbye to him. Or another example, okay, you're in pain and you're sad, that's okay, I feel the same, but now we set our emotions aside and we need to focus on the mission. We get back to feeling the emotions later. Well, actually, it's a project done not only by me. The name of the project is The Last Will. Together with one of the colleagues who's here in the audience, I believe, we did an intervision session. We met and we realized we were interested in the topic of losses in the army, and we researched that topic, how that's done worldwide. And we wanted to introduce this to our Ukrainian army. And we came up with the last will, with the testament, and with the farewell letter. Well, by the testament, I mean all the legal documents, like your legal will. And this is a tiny brochure I hold here. So what is that about? What does that triad speak about? The last will is something we took from the Danish organization called Life and Death. But it's not just a translation. It's an adaptation. It's adapted to our regulations. We've incorporated information about DNA body identification. We've included information on digital legacy, and we've also incorporated many nuances coming from our regulatory system. Page 1 shows different data for identification: name, passport detail, military token, or a DNA strand. Further information on contacts, on emergency contacts, to notify about the case of the death. There's also information on religion, about how a person wants to be buried, which ritual should be followed, the religious ritual or some other, what music needs to be put on, should the flowers be there or not, who needs to carry the coffin, how the coffin should look like. So nuances abound. To what end are they there? Well, first, they help the family of the deceased, because, you know, the family is naturally shocked at the loss. They struggle controlling their behaviors, and they struggle with the choices. But the soldier has explicitly stated here what they want. That's a side effect, by the way. But our primary goal for launching the project was as follows. This is all about experiencing your own loss. It's about acknowledging the finiteness of life. This reduces anxiety, and thus you have more energy. This energy can be channeled towards military action, towards fulfilling your mission in an army. Right, what else do I have to say here? I'll expand on the project that I mentioned before. There's a different part to that. There's a farewell letter there, and it's also critical. The reason being, especially nowadays, the thing is that men and women in extreme situations and men and women run in different directions, and they didn't even have a chance to talk. And this farewell letter could clarify it with the family. They could explain why the person went to war and for the sake of who they took up arms. So reading this letter is like your chance to have a conversation with a person who's already dead. These are lines about love. These are the supports for the future. This is testament, the legacy. This is the ritual of saying farewell. For the writer of that letter, I mean, if you ask yourself now, have you ever thought, at least people who are among the audience and who live in Ukraine, have you ever thought, what if I'm dead? I believe every Ukrainian thought about that. No matter how we avoid them, how taboo we make them, we're in the context of war. These thoughts crossed our minds inevitably. It's about anxiety, and it's a waste of energy. An energy that could be used for a better purpose, such as living in general. It's worth doing for the sake of channeling this energy back towards life. You need to accept and acknowledge that life is finite, but we're still alive, and we need to do something while we can. Now, to sum up, leadership as a part of a social support network is a crucial factor influencing a grief process. Correct actions of the leaders facilitate grief. They also help to restore and diminish risks of complicated grief. This is a hypothesis. I do not have the evidence to corroborate that, but I'm pretty certain, but this needs to be tested and corroborated through studies. Obviously, the war context needs to be taken into account, and grieving has its nuances, both in civilian and in the military personnel. This is everything I had to say. I had about a quarter an hour. Maybe I went over a little. I'm hopeful that my contribution was helpful as well. Thank you.
Yeah, thank you. Thank you, Galina, very much. And meanwhile, I imagine our colleagues might be interested to get more information, how they might get access to this. So you can put in the chat any contact details. Meanwhile, I would really love to hear your colleagues, Andriy Karachevsky, and maybe Oleg Hukovsky as well could comment. Andriy, будь ласка.
Добрий вечір, колеги.
Good evening, colleagues. Many thanks to Halyna and Oleg. They sent me this last will about 2 months ago, I think. I cannot say that these 220 copies were exceedingly popular, but I did fill it out. It was especially helpful because, you know, this medical reconnaissance is helpful, you know, when you make up your own mind and find out things for yourself. In the medical service, these leaflets were just there, and the soldiers could see these documents, this last will. I wouldn't say people really took them. A couple of them, maybe, a couple of soldiers. Therefore, I have no statistics or feedback for you. But it was very helpful for me personally. Thank you. Thank you for your feedback, Andriy. That's helpful too. We didn't expect that these would be very popular. We get some individual requests now. You need to work to make it more popular. Unfortunately, we're low on resources at the moment. Halyna, but I know some psychologists who incorporated this piece of work in their work, and at least they distributed it among their family who are servicemen. Andriy, I also have this copy filled out by my husband. Halyna, as for leadership, well, usually unit leaders, they correspond all the 3 bullet points that you mentioned. The casualties, unfortunately, are there. The casualties are severe. Andrei, this is the reality. Halyna, well, I was in contact with those units who lost 2 or 3 people at the same time. It's a difficult process.
Yeah.
But nevertheless, thank you.
Yeah, I was amazed how Halyna at the same time was talking about such important and tough things and smiling at the same time. I felt myself, yeah, kind of soothed and relieved. Thank you. And yeah, I see that we run out of time. I hope, yeah, we will just wrap up this after several comments from our colleagues like Oleg Hukovsky, and I would like to refer to you, Paul, again, to maybe to have your final comments, and yeah, and then we will finish. Oleg?
Вітання.
Welcome. I saw a question in the chat where you can download the document. We have the printed copy you can pass on to. We also have a digital copy in place. I know that they have been sent to units fighting on the front line. Those people who want can fill out the digital copy. It's a Microsoft Word document, and then they sent it and they created a separate postbox.
Paul, would you like maybe to comment or to provide your feedback?
Well, only very briefly, because there are perhaps others who would like to ask a question, but I thank you for your wonderful talk, and I just agree, and I can well, I think it's important work. Grief as a forgotten emotion, those are words that's in translation that are keep running through my mind. Is I think very key to what you said. Grief is often a forgotten emotion, and it's good if the social environment helps to articulate and express the grief. And I really agree that leaders can play a tremendously important role, and not that we have to sit down and grieve all the time, because that's not what we need. But it's acknowledging the pain, acknowledging the reality of the loss, acknowledging the importance of people's lives, acknowledging sadness. That's what leaders can do, and what leaders can foster in the environment of people. So thanks. I found it very nice and helpful to hear, and it added to what I told. Mm-hmm. And stresses the importance of the wider social environment. So thanks.
Yeah, thank you. Before we will finish, I see here 2 hands and I cannot ignore them. So let's hear short questions, I hope, from Olena and Tatiana, and then we will stop. Olena?
Дякую. Я навіть би хотіла, можливо, навіть прокоментувати. Доповідь Галини, вона надзвичайно потужна.
I have a comment on Halyna's input. A very powerful talk. I have personal experience of planning one's own death, what they say, the final will, as it's called now. At the time, I did not know about this approach, but I have heard about approaches in other army. So it helps a person to accept the probability of their deaths. We used this among some of the Marines, and after people got back, they were prisoners of war, and then they came back and they were no longer prisoners of war. They did this exercise and assignment, and this helped them accept their situation, their pain, and to be more rational and to act more in a more meaningful way. This was supportive for their families as well. The families who have accepted and acknowledged it, and they were ready that situation could unfold in such a way. So this approach is effective if used correctly. It's extremely effective. you need to send it to the unit. But you need to be very careful when you send an e-copy. You need to really prepare people so that they can work with this type of material. Halyna, thank you. This was an incredible meeting today.
Добре. So we have last question, I hope, from Tatiana. Are you still with us? And while Tatiana is turning off her microphone, I will put a short questionnaire in Zoom right now, just 2 questions. Please do answer. And as well, yeah, Tatiana? Okay, not sure that she will be able to.
Hello, and thank you for this presentation. Indeed, it's very, very helpful. Me, I managed to look at the situation from a different angle. But it led me to a question. In Ukraine, talk about death prematurely. So some people might be depressed. Wouldn't it depress people if they think about death even before they go to war? What would you say? Thank you for this question. As Ms. Olyna has said, it definitely no, it should be based on trust. So the psychologist has to have the report, and it's not, of course, on the first or the second meeting. And this is done on the stage of preparation, when people are only starting their service, when the units are formed, when they start talking to a psychologist about combat stress and responses. And this topic can be raised. It's not that you have to give this out to everybody. There is a certain algorithm, something similar to a motivational interview, which would maybe encourage some conversation on this topic. And then you can fill it in. Or it can be done at the stage of the rotation, after soldiers already had some active combat experience and they are back in their station. But of course, it's not done like right before they have to go into active combat, except there is some individual request for this. Because, of course, some people might resist. If you do this like a day before they have to go in combat, it might really depress them. It's like, okay, so you just want me to die. Of course, you have to be very careful and you have to consider the circumstances appropriately.
Yeah, thank you.